For those of you who don't know me, I'm a pharmacist. I work with South Tees Hospitals Trust. I work in the oncology department there, and I am about to submit my consultant pharmacist portfolio at the end of this month or beginning of next month. So my post has been accredited to be a consultant pharmacist post, and I'm just in the process of proving, hopefully, that I'm good enough to be a consultant pharmacist. So I'm going to talk about various things in this session, partly how to get hold of data to work with, how to some of the challenges of working with others. I'm going to talk about how either to break your own data or how other people might break your data, just very briefly. I'm going to talk about study design at a very high level, just some concepts, and some of this is more reflection on how things have evolved for me. I'm going to talk about trying to make sure we pick meaningful outcomes rather than outcomes that are traditional to pharmacy. I'm going to briefly touch on data protection and some of the changes in the rules that have come in around that. And then I'm going to try and link all that together with how some of that fits into the consultant pharmacist framework. So the consultant pharmacist framework, for those of you who don't know, has 5 domains. There's a patient care domain, a communication domain, a leadership domain, an education domain, and a research domain. And since this is a research conference, I'm going to concentrate purely on research. Within each domain, it then splits out into a number of areas, and then each of those areas splits out into more detail that describes the behaviours you should have to prove that you can do things. So the first is that the first research criteria is that you should be able to critically evaluate literature and evidence. The second is that you should be able to identify the evidence gaps and then design research to generate new evidence to fill some of those gaps, and that you should be able to work collaboratively to support research. So I'm going to try and talk through how some of that's happened for me. I'm going to start, most of my presentations run with a story, and that's how this will begin. So a few years ago, when biosimilar rituximab was being introduced, we involved various people in some discussions of trying to preempt what the concerns might be around implementing biosimilar rituximab. It offered significant financial savings to the NHS. And so we wanted to be able to do it as quickly as possible, but we thought there might be some clinician resistance. We thought the most likely area of resistance might be that if we were unlucky enough to have the first patient who we gave it to had an infusion reaction, then of course instantly everybody attributes that to the new product, and suddenly there'll be a lot of resistance. And to make matters worse, we couldn't simply say we should follow the evidence that's been published on the biosimilar, because the biosimilar used the licensed infusion rate. And within oncology, or rather within hematology, we use rapid rituximab, so administration over 60 to 90 minutes instead of administration over 4 to 6 hours. So because we're giving it quicker, it's possible that our infusion reaction rate might be higher. Our first question was, well, actually, what is our baseline reaction rate? And we didn't know. There's no system that reliably collects that data. You can go and look at yellow card reports, but virtually nobody would report those reactions because they're expected reactions, even though sometimes they might be quite severe. You could go and look at your IT systems in your trust, but virtually no trust has a useful way of recording that kind of information. So it'll be free text recorded somewhere, and the quality of that data would be very poor. So we thought about what data we might need to collect, and we started to think about what other confounders there might be. So would it be the dose that might change things? Would it be the cancer type that the patient had that might change things, etc.? And we knew from a previous project I'd been involved with that different people would tell you that an allergic reaction had been severe or very bad or whatever, and actually you needed a consistent way to be able to score it. Even though we have a consistent way within oncology for scoring toxicity, application of that still remains quite varied. And then once we had that, we thought, well, how many patients would we need to look at to be able to give a meaningful answer? Most of these sorts of projects that you're doing, you might only have 20 patients in your trust. And if you've only got 20 patients in a trust, it does coming back and saying, I've got 2 patients out of 20 who've reacted. Does that give you any reassurance or not? So we started off by going back to the literature and reviewing the literature. We found several papers and did a meta-analysis on those. So we got nearly 2,500 patients in 2 different rapid administration regimes, and got an allergic reaction rate of just under 10% for any grade of reaction, and less than 0.5% for the more severe reactions. We took the confidence intervals around those estimates and said, well, actually, if we're using biosimilar rituximab, we should hope for a reaction rate less than the upper limit of the confidence intervals. So 10.8% and 0.7% were set as our audit standards. And we, in a collaboration of discussion with other people, effectively brainstormed the factors that we thought were likely to be contributing factors. There was a bit of literature review sucked into that, and we came up with 52 data fields that we wanted to gather data on. We built an Excel spreadsheet. I'll talk more about Excel spreadsheets later probably, but Excel spreadsheets are very convenient as a way for people in different organizations to populate data and then to merge that data in later. They're also a very convenient way for people to send you data that's not structured in quite the same way as you intended them to. This was probably my first experience of collecting data from multiple organizations on an Excel spreadsheet and discovering that people would just enter dates in different formats and things like that. However, at the end of the project, we ended up with 75 patients worth of data, slightly less than we'd hoped for. We struggled with recruiting hospitals to be part of the project because actually it turned out not to be as big a concern as we thought it would be. But we got data from 116 rapid infusions and the infusion reaction rate was very low, so it was quite reassuring. And so we were able to carry on safely giving rapid infusion rituximab. There's been a similar project from one of the very big London hospitals who had about 100 odd patients themselves, and they've also published their data and shown that there's no significant difference in infusion reaction rates there either. The next project that we came on to talk about was a meeting of NHS England cancer commissioning pharmacists, and it was a discussion around waste. One trust was saying, we think we're being charged for waste centrally into NHS England, and we're not sure if we should because NHS England doesn't control that waste. And the NHS England commissioner said the person who should be paying is the provider, they've created the waste. And someone else would say, but actually there's trusts who tell us they have no waste, but they're probably just burying their costs. And so we don't think that's true either. And then we got to the fundamental question of what did we mean by waste? And it turns out that everybody means a different thing when they talk about waste, particularly waste with chemotherapy. So we had a situation where one provider would say waste with chemotherapy meant we made up a bag of chemotherapy, we sent it to the chemotherapy unit for the patient, and the patient wasn't well and didn't get it, and that's clearly waste. And another provider would be talking about the dregs at the bottom of the vial, they used half a vial and didn't use the rest. And different providers would argue that their model was producing less of one waste and more of another and so forth. And actually, it didn't matter which one was which, because we said what matters is how much drug got given to patients for the cost that we're spending. So we said if we had an ideal data set, we would simply have a table from each trust telling us for each drug how much drug they used, how much drug they'd given, and we'd be able to work out how much of that drug was wasted. We said, well, actually, those first two columns could come from your pharmacy computer system. You already know how much was used by the pharmacy. And the two purple coloured columns should be able to come from a data set that's routinely being collected in your e-prescribing system for chemotherapy, known as the SACT data set. It's a data set of 43 fields for every single dose of chemotherapy that's given to a patient, uploaded to Public Health England at the end of the month. So we said the data's there, we just need to get it into the right form. If you go to your pharmacy system, this is an example what the Ascribe system might produce. And as you'll see, it's got data on there for chemo drugs, but it's got non-chemo drugs. It's got patient identifiable data. So let's start by filtering off the things we don't want. So we didn't need to get down to patient-specific level, and we certainly didn't need to know about the non-chemo drugs. Ascribe also shows things that were manufactured in the aseptic unit, so we'll hide those off too. And we get down to just the raw ingredients of chemo produced. You could filter that out in your reporting system, or you could filter it out once you've reported it to do it later. And we said, well, actually, none of that tells us how much bortezomib we've used, because the only place that the quantity of bortezomib is anywhere to see is in the description, and we can't process that information. So we built a lookup table which took the product codes and was then able to tell you that bit of information. So we needed to do a one-off bit of work to create that information. It doesn't take terribly long to do, and you can then reuse that multiple times as you rerun the data. You can then join that, and joining is a process that you can do in good quality data analysis packages. You can even do it in Excel with a little bit of effort, so that we could pull up into our original data set the number of the drug name rather than a description with lots of other information, and the number of milligrams in that vial size. We could then calculate out from that the actual number of milligrams used. So you'll see on the third row down that they use 2 vials. So instead of being 2.5 milligrams, it's 5 milligrams. I'm talking you through some very simple maths here, but to try and make this make sense. Then we summarized that for monthly data. We didn't need to work on any more level of accuracy than that. So you got the total number of milligrams of bortezomib you used in a month and the total number of milligrams of carboplatin. We did this for 20 drugs, but for the purposes of keeping the screen reasonably clean, I've just looked at 2 drugs. Then we took the SAC data set, which is this giant data set of data that every trust is uploading. There's multiple fields. I've just selected out the relevant bits. Again, we didn't need any of the patient identifiers, so we just deleted those out of the data. And we only wanted certain drugs, so we deleted drugs we weren't interested in. And again, we summarized that by drug. And we got a table that looked something like this. So this was the number of milligrams we'd actually recorded as administering to patients. And then we merged those 2 together to get the same information all in one table, and then you could calculate out the waste as the number of milligrams wasted. Depending on your viewpoint, you've wasted more carboplatin than you have bortezomib, because carboplatin you've wasted 50 milligrams of, and bortezomib you've wasted 5.2 milligrams. But if you look at it as a percentage, it's higher. And if you look at it as a cost, which was the discussion that we started out with, then actually you're wasting a lot more on the bortezomib, and that's where you should focus your effort. Each trust, so we then collected that data across all the trusts in the country, the country being England, for 20 drugs of interest, and gathered up some data, and we're able to produce a number of analyses of that in a variety of ways. But one of the things we were able to do was produce this waterfall plot that showed the expenditure wasted. So if your trust was spending £1 million and you were wasting 25% of your chemotherapy drugs, that's £250,000, which is quite a lot of money. And so you could see where you as an individual trust were. This is just an extract taken from one of those reports, and that red arrow is where that individual trust lay, so just below the median, so they weren't doing too badly, but there was room to improve because there were trusts who were doing better, but you certainly wouldn't want to be a trust on the right-hand side. And it helped trusts to identify whether or not they were doing okay or not, because up till then they didn't know. Good research always generates new questions of its own, and in fact that's pretty much what this project did. All it did was gave people an opportunity to debate the data more, so people were starting to ask questions about why their waste was higher, or what they could do to reduce their waste, and it got people talking between different trusts, because they could go and say, well, your waste's lower, what are you doing different, and so forth. It got people to challenge the data, and we absolutely expect that there are trusts in there that have data that was flawed, but if that all it did was meant that they went and improved their data for their SAC data submissions, well, that was a valuable exercise in itself. But one of the important things for that whole project was that it got people to start saying, no matter what we do, we need to reduce waste, because we are wasting tens and hundreds of thousands of pounds of chemotherapy a year in individual trusts, whereas until then, nobody had ever put a financial value on it. That then brought me to my next project. So my clinical director does my appraisal now rather than my chief pharmacist, and he sat me down for what I assumed would be my routine appraisal, and he started off by complaining about the number of new treatments we kept getting approved and how busy we all were, and the fact that we didn't actually have enough time to manage all of this, and the fact that more oncologists are retiring and the whole problem was getting worse. And I said, well, that's why you've employed me. And he said, well, yeah, that's great. And, you know, it's great that you're fully trained and you've got bits of paper to show you're a non-medical prescriber, but what's the evidence this works? And I said, well, the evidence is easy. The evidence is this publication from 10 years ago that says non-medical prescribers make less prescribing errors. And he said, well, actually, making less prescribing errors is fine, but I make prescribing errors all the time, and pharmacy pick them up and fix them, so the patient doesn't come to any harm. How do we know that you make the right clinical decisions for the patient to proceed with their chemotherapy or not proceed with their chemotherapy? That'll never get recorded as a prescribing error. And I gulped a bit and said, I don't like the sound of this. This sounds like it's going to be hard work. And I said almost at the same time as he said it, how do we know doctors are safe? And what we do with doctors is they present all their cases of death within 30 days of chemotherapy at a monthly meeting. And I said, well, that's easy. I'm doing that too. So my cases go to that meeting. And if I was the last person to see the patient, I present the patient. But I only present 1 or 2 patients a year because fortunately we don't have that many deaths. And so we then said, well, the meeting's called morbidity and mortality. We should look at morbidity. So that's what we decided to do. We took the first week of each month for the first 3 months before COVID hit, and we looked at all my clinics and went through, merged in some SAC data in much the same process as I've described for the merging in of other data. And then we went through our other clinical systems and identified whether or not the patients got admitted to hospital within 30 days of chemotherapy or died, or whether or not they got admitted before their next clinic review. We didn't know which outcome was the right one to use, but we've now actually settled on the 30 days. And so we did that to prove that we were providing a safe service. And indeed, this is a poster we published last year at the BOPA conference, where we showed that actually our rates of hospital admission are very similar. They meet or are less than, in fact, the expected level in the one published paper of rates of hospital admission after chemotherapy, and that there's no statistical difference between the two. And as we did that, we'd built quite a lot of automation behind producing that information, partly because I'm lazy and partly because I'm a geek. So I didn't want to have to go away and look up lots of bits of information. So then we started to sit down and say, what else can we do with this SAC data? We keep sending off these reports to Public Health England every month. And while Public Health England send us back some summary data occasionally and tell us where we've got gaps in our data and so forth, we're not doing anything that's going to change patient care with that. One of the clinicians said, but it's missing survival data. That's one of the problems with SAC data, is that we only can tell Public Health England that they died if they died within 30 days of their chemotherapy, because we upload the data within 30 days. And I said, well, hang on, we uploaded the survival data from a different system for the last project. We can redo that and merge it in with the SAC data. So that's what we've done. This is a work in progress. This paper will be hopefully published in the near future. So we've purposefully hidden the details of what the regime is and so forth at the moment. But these are 3 chemotherapy regimes funded by NHS England to treat the same cancer. Clearly, you'd want the red line, which is the most effective treatment. The other 2 treatments we tend to use if you're not fit enough to have the red line, but the green line is pretty much not any different to the blue line, but is a much more expensive treatment. It's never been in a head-to-head study quite how it should have been as a clinical trial, and so that's what our paper will challenge, is whether or not we're using this treatment in the right setting or not. But this is a clinically meaningful outcome for patients. This isn't an error rates or anything like that, which is the types of things pharmacy would tend to traditionally look at. Part of that project required that we started to look at, when we come to publish that data, we're going to have to be squeaky clean in terms of information governance. We didn't want to get in a situation where we couldn't publish because we hadn't got patient consent, but you don't need patient consent to use data that's already been collected. But as you're probably aware, there's a little bit of a public outcry at the moment about NHS Digital taking data from GP surgeries and being able to share that data with other people. And there is a 2-tier process for opting out of that. So you can either choose to opt out of your GP surgery, supplying that data to NHS Digital, or you can choose to opt out nationally to stop NHS Digital using any data they've got. And if you opt out nationally, that actually applies to trusts not being allowed to use that data as well. So we said, well, we better comply with that process. In fact, it was supposed to be a mandatory process from the end of March, and it's just been moved to the end of September. But we've complied with that process anyway. So we've been through that process, which involves sending off effectively a list of all the NHS numbers that you want to do your data analysis on, waiting for a reply, which takes about half an hour or so, and you get back a reply of all the NHS numbers you're allowed to do your analysis on. And for our 1,400 patients that we've got in our SAC data set, about 300 had chosen for their data not to be used. So it's not that many really, and it's the right thing to do to exclude them. That same process should be applying to any use of NHS patient data, for any purpose other than patient's direct care. And that's going to present some challenges, and we'll need to think about how you do that. That process of joining that I described earlier data is exactly the same process we used for that. Clearly, we weren't going to go through 1,400 individual patient lines of data. In fact, because there's a line in that data for every time we give somebody chemotherapy, there's about 350,000 lines of data. We certainly weren't going to go through 350,000 lines of data looking for 324 patients. So we merged that all automatically. The rest of this diagram I've left in purely because I also wanted to talk about how you think about how you write up your publication. So if you come to publish this in a peer-reviewed journal, you'll be asked to provide a consort diagram if it's a clinical trial, or a strobe diagram, which is what this is. The two are very similar. If it's a observational study, which is what ours is. And that helps you to define what happened to your data and your patients, and about how your data becomes reproducible. But I think it would be very helpful if you're thinking of designing a research project that you think you might want to publish in a peer-reviewed journal, that you actually go and look for what the requirements are for journals. And that usually means looking at the Equator Network. They have a website which will then tell you what standards you'd expect it to meet. And that would usually say you need a consort diagram or a strobe diagram. So I just thought I would put that in more as a prompt to remind me to mention it. And these 5 things are my top 5 tips. These are the sort of 5 things I would say to you if you are thinking of being a consultant pharmacist and wanting to do research. These are the things to think about. You need a network, and that network might be within your trust. That network might be nationally. That network will start discussing and generating questions. You're likely not to do that in a way that is set out where you say, oh, it's Tuesday afternoon, we sit down and have our what research do we want to do afternoon. This is much more likely to be people just discussing patient care or challenges that you might be having and how to proceed from there. That's how almost all of my research has started, is that a group of people, it might be 1 or 2 people, it might be multiple people having a discussion, and it depends whether that's in a trust or wider, which starts to ask a question. And then you need to start to refine those questions, and you might use your network to do that. And the other reason a network's really useful is that they can share some of the work. So they can either provide data from multiple trusts to make your data set bigger, which will make things much more meaningful, or they might share some of the work in terms of the analysis or data collection if it's a manual process, which means you can get results quicker, which means you can make differences to patients quicker if there's a difference to patients to be made. When it comes to designing your study, think about the outcomes that matter to patients. I think we need to get away from traditional pharmacy outcomes, which are usually around drug savings and usually around errors and things like that, and start to think about the outcomes that actually matter for patients. So if we're making drug savings, can we actually show where we've made the investment, where that money that was saved got spent on other things or whatever, which might be a useful way of looking at it. I've mentioned looking at the Equator Network so that you design your study from the start to be right. The other thing I would say is try to understand the research methods or the statistical methods behind what you're doing. You're probably not all going to become statistical experts, but if you think back to that Kaplan-Meier survival curve that I showed with the 3 lines, understanding how those lines are created and what they mean helps you to understand what data is you need to collect. So to draw a Kaplan-Meier survival curve, which is something that is gold standard in any oncology project, you need to know, has the patient died? But you also need to know, if the patient hasn't died, when did we last know they were alive, what we would call a censoring date. And if you've got that information, you can join all the other bits together. I would encourage you to join data from multiple data sets together if you need to, and I would encourage you not to manually enter data if you possibly can. I still have projects that are involved in manually entering data. It commonly will produce data entry errors, and it actually makes life more difficult because people are doing things twice. It'd be much better to get the data entry right on the original clinical system and then extract that data out if need be. And then if that data is in multiple systems, extract the data out with a common identifier like their NHS number. You can join them together without an awful lot of effort. Pick the right tools. So almost all of my research has involved Excel, and for the main reason that Excel's installed on pretty much everybody's computer. we've got a current project going on which includes hospitals in Scotland and across the whole of the UK. And Scottish Excel is at least one, if not two versions older than my Excel, and I've got other trusts who are at least two, if not three versions of Excel more modern than my version of Excel. And every time we hit a data problem, the first issue we have is we don't know whether it's their version of Excel that's breaking something or something we've done in the Excel spreadsheet. There are things you can do to try and reduce the risk of people breaking data. Dates in Excel I find particularly problematic. People enter dates in funny ways. They put decimal places in instead of slashes. If you have international people, you will get people entering American date formats of month, day, year. And even if you don't do all of that, for reasons that are difficult to understand, Excel might just suddenly decide to do that. With the waste project, we had data coming from 150 trusts, and despite the fact that the Excel spreadsheet was designed specifically to give the data output in day, month, year format, it would seem that if your trust's standard configuration on the computer was month, day, year, the data we got sent was month, day, year. So we had to then work out which trusts were sending us that in the wrong format, flip it to the right format so that we didn't break other things. But one of my biggest problems with Excel is it's not reproducible. So you can collect all your data in Excel, but if you do your analysis in Excel, if you've got your first 100 patients' data, you probably want to have a quick look and make sure you're collecting the right bits of data and start to run some of your analysis and think about how you might structure your report and so forth, even though you might want 1,000 or 2,000 bits of data. If you do that in Excel, you do it once, and then in 6 months' time, when you've got all your data in, you have to do it again, and it's not going to necessarily be done in exactly the same way, and lots of clicking and so forth. When we did this for the waste project, we wanted to do exactly the same analysis across 20 drugs, across 150 trusts. I can't do the maths in my head, but there's quite a lot of times of doing the same analysis. So it's better if you can to do it in the right tools that will reproduce things for you. And then finally, my thoughts are around how you publicize and share your work. So there's obviously things like bringing work to conferences like here. There are online discussion forums to go and discuss things, and that's a good way of networking. It's also a good way of shouting about something you've done. Twitter, while it's a evil, horrible social network platform for Donald Trump to publicize his wills with the American people and so forth, the reality is that it's also a very good platform for medical professionals to share data and information and research and ask questions. So if you stick to purely sort of medical or pharmacy Twitter within Twitter, then actually you can use it as a source of CPD. It gives you pointers as to where to look for things, and you can use it to shout about your own bits and pieces of work. There's a social network platform called ResearchGate. They probably don't call themselves a social network platform, but that's effectively what it is. It's a file sharing system where you can upload details of the current projects that you're working on. And for about the last 3 or 4 years, I've been uploading projects that I've been working on into ResearchGate as a way to leave a copy of a poster after a conference to still be accessible and visible. And then finally, think about publishing in journals and so forth. When it came to writing up my consultant pharmacist portfolio, being able to go back to ResearchGate and pull off all my posters and so forth was very useful. The other thing that ResearchGate was useful for was being able to find people who had similar interests, and sometimes people will just randomly send me a message. Sometimes for a project that I did maybe 10 years ago that I've put on ResearchGate and I've pretty much forgotten about, but somebody might just drop you a message out of ResearchGate all of a sudden to say, we're looking at this locally or whatever, often from another country. So those are my top 5 tips as to what I think would be helpful for people who are thinking of going down the consultant pharmacist portfolio. I haven't been looking at the chat, and when I tried earlier, I nearly lost the presentation. So I don't know if anybody can tell me whether or not there is anything on the chat.
There's a few questions, Callum.
Yay.
Actually, since it's a small group, why don't you just unmute yourself and ask Callum directly? I think Julia was first. Then Jessica.
Comment really about, I just agreeing with Callum's point on moving away from focusing on the process, although obviously we want to remain safe, to just a more meaningful patient experience in terms of outcomes, particularly in obviously an area like cancer, but in any healthcare area. Just pleased to see that point raised, I guess, and obviously Callum's point about perhaps having that reflected back in your meeting that you had with the clinical director, and just expand a little bit on how that had led you to a different way of thinking.
Yeah, so my CD does my appraisal. So my appraisal is not done by pharmacy. So that's changed the whole way my appraisal works, because he's a doctor. Doctors don't really know how to do appraisals. I think they would openly admit that. And so he said, I'll just do it like I do the other doctors' appraisals. And so he challenged and sort of said, we need to look at outcomes. And actually, in terms of research, that's the bit that matters. And when you think that actually pharmacy does lots of bits of research, but it probably doesn't make it very often beyond the pharmacy sphere, I wonder how much of that's because we're not looking at outcomes that really interest other people. We look at outcomes that interest pharmacists. And if we want to make our research really start to count, then maybe we should start to look at outcomes for patients.
Javed's asking, is there how can we collaborate with you?
So if people want to collaborate on cancer projects, I'm more than happy. So the easiest way to get hold of me is probably to find me on Twitter. I'm a bit of a gobby get on there, so I'm known as Shiny Black Shoe on Twitter. Or you can drop me an email at callum.polwart@nhs.net. I'm Callum with one L. That's the only tricky bit. So Polwart's with POLWART. Drop me a message in the chat and I'll pick up an email address, whatever you want. If people have things they want to talk about, I'm more than happy to. I'm equally a hardcore geek, and so if people want to talk about data and how to do things with data, that doesn't need to be cancer stuff. I'm more than happy to have a conversation, point people in the right directions and so forth, and get involved with things that aren't cancer. If it's how can we do some cancer data, then absolutely I want to talk.